Thank you, Sue. Um, Welcome. I'm Andrew Gabriel. Some of you will have seen me doing other presentations. Just a little bit of background. I'm not a clinician. I'm actually a patient on hormone therapy myself, so I'm sort of familiar with it firsthand. Um, I do various talks, which some of you may have seen. This one is different from the one that I'm currently giving to most of the support groups. This one describes how hormone therapy drugs actually work inside your body. Another one that's some of you are more familiar with is a talk called Surviving Hormone Therapy, which is a little bit more about how you handle being on hormone therapy. There's actually no overlap between these talks at all. I'm also perfectly happy to come and give this talk to any of the groups that want me to do that, in which case obviously you get the opportunity to ask your own questions, even though there will be a recording of the talk available. So just to sort of get in step with this, I've quite often asked questions about hormone therapy. Why am I on? Why is this happening? Why have I got to take these drugs and these drugs? So I thought it would be useful to actually put this together for prostate cancer patients who actually want to know more of the nitty gritty of how the drugs work internally. So I'm just going to sort of show you some of the common hormone therapy drugs that are in use today. So here we've got different categories of hormone therapy drugs. The simplest are the anti-androgens, things like bicalutamide, or also known as Casodex by its brand name. Cypertrone used less often. It's actually used for other things related to prostate cancer as well. Then the more common drugs are the injections, of which we've got things like Zoladex, Prostap, and Decapeptyl. And for anyone listening in the US, Lupron and Eligard are just different brand names for Prostap. They're all leuprorelin as the underlying drug. Degerelix, and a new one that's sort of appearing called Relugolix, which is actually tablet form, which is a little bit new for the drugs in this category. Then we've got some second generation anti-androgens, enzalutamide, and newer on the scene, apalutamide and darolutamide, which is still going through approvals in the UK. Then we've got a category of drugs called androgen synthesis inhibitors. So I've got in here finasteride, dutasteride, and abiraterone. Finasteride and dutasteride are actually not used for prostate cancer hormone treatments. They are used for benign prostate hyperplasia. But I was specifically asked beforehand about those, so I will include them in the talk, and they're actually quite useful stepping stones for discussing how abiraterone works. Abiraterone is also an androgen synthesis inhibitor, and I'll explain what that means when I get to these, as well as also being an anti-androgen. Then there are drugs called estrogenic drugs, and all the others up before this point are not female hormones. So I quite often hear people say, "Oh, you're on the female hormones." Well, no, you're not. But actually, there are some hormone therapy drugs that are female hormones. The very first hormone therapy drug was diethylstilbestrol, or usually just called stilbestrol, which is a synthetic estrogen. It actually worked quite well, but it had one really bad side effect, which actually caused death in quite a number of the people that took it. So as soon as the newer drugs like Zoladex, Prostap, Decapeptyl came along, stilbestrol fell by the wayside, though it is still used sometimes, so it's not completely gone. And there is a trial using estradiol patches, again trying to get back to the effect of using estrogenic drugs, which can work quite a lot better than the current drugs today, providing we can get past this issue of the one particularly bad side effect that stilbestrol had. So what I'm going to do to start with is to explain actually how the testosterone regulation works in the body, because that's a kind of foundation for which I need to work on then to show you how the hormone therapy drugs themselves work. So to do this, I'm going to do a bit of a chalk and talk type session. And we will start with a prostate cancer cell. Now, of course, prostate has a number of different types of cell in it. But that's kind of not very relevant for this, so I'm just going to assume a simple prostate cell. Now, the prostate cell has a receptor on it, which is specifically for picking up a certain type of hormone, and hormones are androgens, so it's called an androgen receptor. So just to explain what androgens are, androgen is a collective name for all the male sex hormones. Something they've all got in common is that they've all got 19 carbon atoms. There are actually quite a lot of them. Testosterone is clearly the one that is going to be best known by you. I will talk about one or two of the others as we go through. They're collectively referred to as androgens. And just for comparison, the female sex hormone collective term is estrogens. And estrogens are molecules that all have 18 carbon atoms in them. Estrogens won't feature very much in this talk, though, so we will mainly be talking about androgens. So the hormone that causes the prostate cell to actually kind of switch on and operate, start producing PSA and the other chemicals it produces, and to start growing, is called testosterone. Testosterone binds to the androgen receptor in the prostate cell, and it's what's called an agonist. This means that it actually signals the prostate cell to switch on and start operating. Now, where did testosterone come from? Well, testosterone comes from testicles. Why do the testicles produce testosterone? Well, they are told to do so. They also have a receptor in them, and that picks up a different hormone called luteinizing hormone. And the luteinizing hormone is also an agonist, so it tells the testicles to switch on and start producing testosterone. Now, where does the luteinizing hormone come from? It comes from the pituitary gland. And guess what? You may see a pattern here. The pituitary gland also has a hormone receptor and receives a hormone which has an interesting name. It's the hormone that tells the pituitary gland to start releasing luteinizing hormone. It has the very imaginative name of luteinizing hormone releasing hormone. That's also an agonist, by which we mean when it binds to the receptor in the pituitary gland, it triggers the pituitary gland to take action, which in this case is to release luteinizing hormone. And the luteinizing hormone, as I said, acts on testicles, causes the testicles to release testosterone. So working back up the chain, where does the luteinizing hormone releasing hormone come from? Comes from the hypothalamus. And guess what? The hypothalamus also has a hormone receptor on it. which is responsible for the generation of luteinizing hormone and releasing hormone. And it's actually another androgen receptor. So it also consumes testosterone, but this is a negative function. In other words, when this androgen receptor is activated, it stops producing the luteinizing hormone, releasing hormone. So this basically forms a classic negative feedback loop. So if we start with a situation where we assume a male who's got no testosterone, what would happen? There would be no triggering of this androgen receptor on the hypothalamus. And being as this is a kind of negative feedback input, this causes the hypothalamus to generate luteinizing hormone, releasing hormone. This will trigger action in the pituitary to cause the pituitary to produce luteinizing hormone. Luteinizing hormone is picked up by the testicles, causes testicles to produce testosterone. And testosterone will obviously go to all the parts of the body that need testosterone, including the prostate cell, but it's also picked up by the hypothalamus androgen receptor. This will start to tone down the level of luteinizing hormone, releasing hormone, which will start to tone down the level of luteinizing hormone, which will tone down the amount of testosterone that testicles produce. And this sits as a negative feedback loop, a classical engineering concept that maintains the testosterone level at a fairly fixed level in each person. It varies quite a bit between different people, but for any one person, it will tend to normally sit at a fairly fixed level. So if we ignore the prostate for the moment, this particular collection of hormone signaling and organs has a name, and it's called the hypothalamic pituitary gonadal axis. Oops. So that describes the mechanism by which testosterone regulation happens in your body. Gonad is a collective term for testicles and ovaries, and in case of female, it's pretty similar, but obviously the ovaries sit in this position, and we'd be talking about estrogen rather than testosterone. Hence, hypothalamic pituitary gonadal axis. Now, let's think how the hormone therapies will interact with this. The easiest hormone therapy to consider to start with is bicalutamide. Now, bicalutamide is an anti-androgen, so it works by binding to the androgen receptors, and it binds more strongly than testosterone does. However, it's not an agonist, it's what's called an antagonist. That means it does not generate the signal into the prostate to turn the prostate on and to produce PSA and to grow new cells, but it actually holds it in the state where it's not seeing testosterone, so it can't see any testosterone. Now, it doesn't just block the prostate androgen receptor, it actually blocks all the androgen receptors in your body. And remember, we've got one up here as well. So it will block that one too. That has an interesting side effect. Now, of course, the hypothalamus is suddenly not seeing any testosterone. And it thinks to itself, oh, we need some more testosterone. So it pumps up the level of luteinizing hormone, releasing hormone, goes to the pituitary, that pumps up the amount of luteinizing hormone, That causes the testicles to produce more testosterone, but it still doesn't help. So that basically this negative feedback loop has been broken. And the effect of this is actually to push up the amount of testosterone in your body. And bicalutamide does increase the amount of testosterone, typically by about 50%. But it doesn't matter because the testosterone cannot be used by any of the cells in your body that have androgen receptors because the bicalutamide has blocked them. So that's how bicalutamide works. While I'm talking about anti-androgens, it's also worth saying this is also how enzalutamide works. It's also an anti-androgen that blocks the androgen receptors. It's much more powerful than bicalutamide. Enzalutamide binds the androgen receptors 8 times more strongly than bicalutamide. And remember, bicalutamide was already binding more strongly than testosterone was. So it kind of explains why enzalutamide is a more powerful anti-androgen. But enzalutamide actually has some additional effects inside the cell as well that also lead to a shutdown of the prostate cells. However, it's a more modern version of the bicalutamide in terms of where it fits into the strategy. So that covers the anti-androgens. So let me put my diagram back together again. My hypothalamic pituitary gonadal loop. If we now consider one of the newer drugs, the one that I shall go for first of all is Digirelix, because that's the next easiest one to explain. Now, Digirelix binds to this receptor in the pituitary gland here, again, more strongly than the luteinizing hormone releasing hormone does. So it binds, and it works in a similar way, but on a different receptor. So it binds to that receptor and shuts down the function of signaling into the pituitary gland to produce luteinizing hormone. So the pituitary gland stops producing luteinizing hormone, testicles stop producing testosterone, and the prostate, again, now won't see any testosterone. Neither will the hypothalamus. So the hypothalamus will think, oh, we're short of testosterone, and it will bump up the luteinizing hormone releasing hormone, but that's not making it to pituitary, so nothing happens as a result of that. The Digirelix, again, is an antagonist at this receptor, so it stops the signaling into the pituitary gland and shuts down the hypothalamic pituitary gonadal axis. Digirelix is not terribly commonly used. It tends to be used with people who've got bone mets, and occasionally it's used in place of the other more common drugs for people who've got heart conditions. It has to be injected once a month, so it's a bit more of a pain, the mechanics around actually having the injection. So we now look at the other hormone therapy drugs. So we'll look at Zoladex, Prostap, and Decapeptyl. They all work the same way. They again bind to this same receptor in the pituitary. But these are agonists. Agonist, that means that when they bind, they signal into the pituitary gland. The pituitary starts generating luteinizing hormone which the testicles pick up. Testicles start producing testosterone, which will go up to the hypothalamus. The hypothalamus will pick this up and will say, actually, we don't need any more, so it will stop producing the luteinizing hormone, releasing hormone, but that's not doing anything. And meanwhile, the Zoldex, Prostap, or Decapeptyl are hammering hard on the pituitary, basically saying, I want more and more testosterone. And that's what happens. Your testosterone level goes up, typically to about 2.5 times the normal level. That's not what we were expecting at all, because the whole object of this exercise is to prevent testosterone, or at least prevent the activation of the prostate cells. Well, there's actually a little bit more to the hypothalamic pituitary gonadal axis than I let on. I need to go back and explain. There's another hormone which comes from pituitary down to the testicles, and it's called follicle stimulating hormone, FSH. Now, that's a bit bizarre because the testicles don't have any follicles in, but ovaries do. And the follicle stimulating hormone, if you temporarily consider this to be an ovary, causes the release of an egg. Now, this FSH is also triggered by the luteinizing hormone releasing hormone, but it's quite separately raised and lowered compared with the luteinizing hormone. So my simple description of this hormone turning on and off or varying its level is actually not accurate. What actually happens is the hypothalamus varies the level of luteinizing hormone, releasing hormone over time, so it varies. And the period of it varies. And the pituitary actually picks up, that is looking at that to decide how much luteinizing hormone to release and how much FSH to release. Now these two together are collectively called gonadotropin. And it's therefore a better name for this hormone is actually gonadotropin releasing hormone. LHRH is a little bit old. You will see both names used. They both mean exactly the same thing. But that's just to explain to you where gonadotropin releasing hormone really comes from, is a collective term for luteinizing hormone and FSH. So having explained that the gonadotropin releasing hormone is actually a little bit more complicated than just a level going from like 0 to 10 or whatever, it's actually a hormone that varies in frequency. The Zoldex, Prostap, and Decapeptyl don't do that. They bind to the pituitary receptor and basically hammer it at full pelt. And after a while, the pituitary realizes, I'm not seeing this cyclic pattern that I'm expecting here. And it actually causes the pituitary to shut down these two functions. So that's how the Zoldex, Prostap, and Decapeptyl come to shut down the testosterone. But they don't do it immediately. So if we were to draw a graph of testosterone against time, and at this time here, you started taking your hormone therapy. So before that point, your testosterone is a nice level, whatever it would normally be. Now, if we go back to the Digirelix, the Digirelix was an antagonist, so it shut the pituitary down really quickly, shut the testicles down quickly, and you lose your testosterone quickly. Basically, for Digirelix, your testosterone does this. However, for the Zoldex, Prostap, and Decapeptyl, the testosterone does this, goes up high until the pituitary realizes that something's gone wrong with the signal, and then it will decay back down. This big area here, which typically goes up to about 2.5 times your normal testosterone level, is not something you really want to access the prostate cells. So this is why when you started taking Zoldex, Prostap or Decapeptyl, you will have been given a dose of bicalutamide, typically starting up to a week before and going on for perhaps 2 weeks after you started the bicalutamide. That acts as an anti-androgen and blocks all of the androgen receptors during this period when your testosterone is going sky high. Now it's actually about, it's about 2 weeks from taking the Zoldex, Prostap or Decapeptyl that your testosterone is back to the level it was, and then it's about another 1 week after that, so about 3 weeks in total before your testosterone is really sort of crashing down towards castrate level, which is the object of the exercise. So that's the reason for taking the bicalutamide for perhaps a week before and a couple of weeks after you start taking the Prostap and Decapeptyl. For people with mild prostate cancer, that boost probably wouldn't matter very much. But if you happen to have bone mets, that could actually cause bone mets to something that you weren't aware of, to something, or maybe that you were aware of, to become quite painful, because they would possibly start growing quite considerably in that period and quite rapidly. So that, I hope, shows where these main hormone therapy drugs plug in to the hypothalamic pituitary gonadal axis, and how they eventually starve the prostate cell of the testosterone that it needs to grow. They work in different ways, but they all eventually achieve the same effect. So I will move on now to talk about the next useful thing to talk about is actually the finasteride and dutasteride. So as I said, these hormones are not used for treatment of prostate cancer, but they are used for treatment of benign prostatic hyperplasia. So I'll explain a little bit more about how that works. Here's our mythical prostate cell again with its androgen receptor. Now at this point, I need to say my description of the hormone feeding that androgen receptor was actually rather on the simplistic level. It's not testosterone directly, it's another androgen. It's an androgen called dihydro, like testosterone, or for short, DHT. Now, dihydrotestosterone is an androgen. Its particular feature is actually that it's somewhere between 5 and 20 times more powerful androgen than testosterone. So you can see why the prostate cell might well quite like to be being given dihydrotestosterone rather than plain testosterone. However, dihydrotestosterone is produced from testosterone by a process of reduction. So there's a chemical reaction that happens in here, and it's reduced by, the reduction is by a hydrogen atom. It gets an extra hydrogen atom added to it. Now you might think dihydrotestosterone, that sounds like it's got 2 hydrogen atoms. Well, you'd be right, but testosterone's got 1 there to start with, so we're just adding an extra 1. And this is done using a catalyst, which is called 5-alpha reductase. Now, the catalyst acts basically to create that reduction reaction. What the finasteride is looking to do is to prevent the creation of dihydrotestosterone. So the finasteride acts as a 5-alpha reductase inhibitor. So it basically stops this reaction happening. So that prevents the prostate from getting access to dihydrotestosterone. But there is still testosterone there. It's not as powerful. It prevents the loss of the dihydrotestosterone, prevents the prostate from growing. Unfortunately, dihydrotestosterone is used in a number of other places in the body. So although the side effects of finasteride are considerably less than the side effects of the hormone therapies used for prostate cancer, they are still present. So you will still get, for example, the loss of libido. It will still affect body hair, because body hair is actually triggered by dihydrotestosterone in hair follicles. But some of the other male characteristics are not impacted because they just rely on testosterone. So it has a lesser effect, but it does work for preventing prostate growth in the case of benign prostatic hyperplasia. Now, this neatly leads on to a description of how abiraterone works. These are a family of what are called testosterone synthesis inhibitors. So here we're synthesizing dihydrotestosterone, or we were from testosterone. Now, abiraterone works a little bit differently, but it's a similar idea. So one of the mutations that can happen quite easily to a prostate cancer cell when it's being starved of the testosterone or dihydrotestosterone that it so loves is it can look around and do slightly different things to generate dihydrotestosterone. Now, one of the routes that it has is to pick up the steroids from the adrenal glands. And by a means that is not very different from the means of converting testosterone to dihydrotestosterone, it can convert the steroids from the adrenal glands into dihydrotestosterone. Now, abiraterone comes in and breaks that conversion. So that prevents the steroids from the adrenal glands from being converted into dihydrotestosterone and used by the prostate androgen receptor. Abiraterone is also, although it's not the main thing here, it is also an anti-androgen. So it will block the androgen receptor as well. But the main function we're looking at for use of abiraterone, because typically this is used at the point where anti-androgens are not working properly anymore, is the destruction of this mechanism whereby we generate dihydrotestosterone from some of the hormones generated by the adrenal glands. So that really covers how the main hormone therapy treatments work. What I am going to go on to now is to talk about a discovery that came to light during the analysis of some of the data in looking at survivors and the non-survivors of COVID-19, because a number of us were sort of pondering, without any scientific background to back this up, along the lines, men have roughly double the chance of becoming seriously ill with COVID-19 and dying than women do. What happens to those of us on hormone therapy? You know, is the hormone therapy a benefit? Would it bestow us with some of the advantages that perhaps women have when it comes to survivability with COVID-19? This was just some idle musings. You know, there are downsides to hormone therapy. Maybe we've got an upside as well. Well, some news came out of Italy, which was quite astounding, actually. It showed not only that this was indeed the case, but actually we were somewhere around 4.5 times less likely to get serious infection of COVID-19. This was based on analysis of men who, somewhere around 4,000 to 5,000 men in Italy who ended up in ended up in hospital, in both just normal hospital care and those who went on into intensive care. Cancer patients as a whole were slightly more likely to end up in ICU and to die than non-cancer patients from COVID-19, which I guess is not terribly surprising. But there was this cohort of men on androgen deprivation therapy who actually were doing vastly better at surviving than normal men, who are not subject to cancer or to to androgen deprivation therapy. And the improvement was something like 4.5 times. In fact, over men who got cancer, it was something like 5.5 times. So it was really quite significant. Now, this points to some interesting, this results in some interesting theories about how the virus gets into an ordinary cell and basically infects the body. There's a protein called TMP-RSS2. There's a gene called TMP-RSS2 which generates a protein, and that plays an important, somewhat vital part for the virus to get into the cell. Now, it turns out that this TMP-RSS2, which is known quite well because it's one of the genes that's very much implicated in prostate cancer, is also expressed quite widely in the lungs. And it's a gene that is triggered by testosterone. So it was quite, it sort of led on quite clearly to the fact that men who didn't have testosterone were expressing this gene less and were producing less of the protein that was used to get the COVID-19 virus into a cell. Now, this is all just theory. The only facts that we have are a correlation from data that have been collected in Italy. And there were some test tube experiments that were kind of showing that this was quite likely a possibility that in the absence of testosterone, TMP-RSS2 gene is not triggered, and the protein that's used by the COVID-19 virus to get into a cell is therefore somewhat absent. This clearly could clearly explain the difference between men and women, although there are plenty of other things that can also explain that difference. But the women do have testosterone, just much lower level than men. But men on androgen deprivation therapy can have some very low levels of testosterone altogether. So there's been a lot of interest in this. And as a result of this, there's a trial, it's called the HITCH trial, H-I-T-C-H, which is intervention treatment for patients in the US with COVID-19. And the idea is very much to give them hormone deprivation therapy. Now, obviously, those of us on hormone deprivation therapy know that it's not necessarily the most pleasant thing to be on because of side effects. But in this case, we're only looking to give these patients hormone deprivation therapy for a month, and basically you aren't going to get any serious side effects in a month. Indeed, not any that you'll notice at all while you're laying rather ill in hospital. So the HITCH trial started off with 4 US hospitals who are doing a blind trial. Men who've entered the hospital but are not bad enough to go into ICU are given either hormone therapy drug or a placebo. It's a blind trial. The trial has started. I pinged an email off to Professor Matthew Rettig last night just to see if they got any information yet, and it is too early. But one thing he did tell me is that they've increased the number of trial sites from 14 to 15 just recently. So this trial is turning into a much bigger trial than it was originally going to be. Now, it's interesting, the choice of hormone therapy drug. Considering what I've just gone through, you need a hormone therapy drug that's going to act really quickly. So giving one of these patients Zoladex, Prostap, or Decapeptyl, which takes 3 weeks to kick in, is not going to be any use. You know, a large number of them will have died or gone into ICU by that point, and that they consider that once a patient's gone into ICU, they are past the point where this androgen deprivation therapy would be beneficial to them. So you're looking for a hormone therapy drug that operates quickly. And you remember the one that I mentioned there was Degerelix. Degerelix comes as a 1-month injection, so it's actually an ideal choice. And they are indeed using Degerelix. There have been some applications to use female hormones as well. Estradiol patch being the one that was being considered. The Hitch trial did look at that, but actually dismissed it because estradiol does actually also generate a testosterone flare, albeit only for about 4 hours. But 4 hours of somebody who's fairly critically ill with COVID-19 could make all the difference in results. So the Hitch trial is not using estradiol, but I noticed there are some applications for trials using it in some other countries. So this may be an interesting development. It may mean that patients on hormone therapy are significantly less likely to get serious COVID-19, but it's too early for you to go out and be irresponsible about getting COVID-19 infections. So don't start doing that yet. Continue protecting yourselves just as you would. But keep an eye on this page, because this may turn out to be one of the possible treatments for COVID-19 going forward. When the Hitch trial reports, I shall certainly be very interested to see what the outcome of that trial is. So it's an interesting follow-on to hormone therapy drugs used for prostate cancer, possibly being used for treatment of patients who've got infected with COVID-19, but are not yet serious enough to have gone into ICU, where it's thought it's probably too late for the hormone therapy drug to have any benefit. Anyway, that brings my session to an end. So really quite happy to answer any questions. Now, I did have 2 questions before. One of them, as I said, was about the finasteride, which I tackled as we went through. A second question was, somebody said to me who'd had a prostatectomy, so I've got no prostate. What effect does that have on my testosterone levels? And the answer, I believe, is none, because the prostate is not part of the hypothalamic pituitary gonadal axis, which does the setting of testosterone levels. So I don't believe that having a prostate removed will affect your testosterone levels. But if anyone has any more questions, please do put them into the Q&A panel. So I've got one here, and it says, why do hormone treatments fail after being used for some time? That's a very good question. Now, if we think back to basically what cancer is a mutation of the genes in the cell. Now, normal cells in the body, or healthy cells in the body, have some corruption repair mechanism. So genes or chromosomes get corrupted quite often in cells due to toxins in your body, or things like UV radiation or gamma rays. And prostate cells, and just as with almost all other cells in the body, have a mechanism for repairing those genes. Now, what's happened with a cancer cell is that that repair mechanism has become broken. So the genes have in the prostate cell have got corrupted, and the cell has, for some reason, lost the ability to repair them. Now, most corruptions of genes would end up with the cell not working properly at all, and it would probably die. But just occasionally, one of those corruptions will have an effect on one of the two key mechanisms that get broken when a cell becomes cancerous. One is the ability of the cell to kill itself when it's reached the end of its life. And the other is the ability of a cell to decide when it's appropriate to multiply and start producing more cells. Now, if those two mechanisms go wrong, or even just one of them in some cases, the cells will start to grow out of control. And that is what happens with cancer cells, and in particular prostate cancer cells. So you've got genes that have become corrupt, and the cell will then either not die, when it's expecting to, because cells control when they die. They die hopefully before they wear out, because you don't want loads and loads of half-broken cells in your body. And they also decide at what point they're going to multiply, because they need more of them. So if a cell isn't dying and it's multiplying uncontrollably, that's basically what cancer is. Now, to start with, those cells require testosterone, the same as any others. So if we remove the testosterone, those cancerous cells stop growing, the same as the ordinary prostate cells stop growing. But remember, those cells have got a broken DNA repair mechanism. So the mutations will carry on happening to those cells, and eventually you'll get a mutation that happens that enables the cell to start growing again in the presence of whatever hormone therapy drug you're using. Now, one of the examples perhaps that's worth mentioning would be bicalutamide. Bicalutamide binds to the androgen receptor in the cell, so actually it looks a lot like testosterone. It doesn't take much of a modification to the androgen receptor in terms of a corruption of the DNA in order for it to actually use the bicalutamide instead of testosterone. So you can see there that if that mutation happens to just one cell, that cell will then be released from the constraints that the hormone therapy has put on it, and it will start to be able to multiply again. In that particular case, this is why when bicalutamide fails, you are always taken off it, because it could well be that bicalutamide can fail for loads of reasons. So this is just one of them. But you don't actually want to start feeding the cancer with what was supposed to be the hormone therapy drug. So that's one example of how that happens, and there are many others. It's very much like antibiotic resistance. So you're pouring antibiotics, if you like, into your body. These are not antibiotics, obviously, but the bacteria becomes resistant to them because a mutation that avoids the cell being clobbered by an antibiotic actually enables that cell to suddenly start growing and become, it's resistant to the treatment you're giving. Well, it's very similar with cancer. These are not bacteria and antibiotics, but it's the same principle that these cells are mutating, and they work around the hazards that you put in their way to stop them from growing. Let's look at another question. Does having a vasectomy break the chain? Which chain would that be? Having a vasectomy doesn't break the hypothalamic pituitary gonadal chain, so it shouldn't affect your testosterone levels. There is some small amount of data correlation showing that having a vasectomy might increase the chance of prostate cancer. but I don't think, as far as I'm aware, there's any known cause for this. And when I've talked about it before, I said it could well be that men that are okay with going to have a vasectomy are probably also okay with going to the GP and having a finger put up their backside. And it may just be that those men are more likely to be diagnosed with prostate cancer. I don't know that there is any, although there would appear to be a slight correlation. I don't think any cause has been identified as to why a vasectomy would affect the likelihood of prostate cancer. What was the possible fatal side effect of estrogen-based drugs? So diethylstilbestrol is a tablet, and you take it, and like many tablets, it goes into your gut, it's absorbed into the bloodstream. The bloodstream from the gut, before it goes to the rest of the body, goes through your liver. Your liver neutralizes toxins in the food that you've eaten before allowing that blood, to carry that out to the rest of the body. Now, men have estrogens in their bodies, and the liver doesn't normally have any problem with estrogens in the circulating blood. It turns out that it actually has quite a bad problem with estrogens coming in from your digestive tract. This actually messed up some parts of the liver, particularly areas associated with blood clotting. And men on diethylstilbestrol tended to suffer from thrombosis quite badly. And actually, thrombosis turned out to be a cause of a third of the deaths of men on diethylstilbestrol. And it's due to this phenomena that's called first pass through the liver. So the drug that you take orally that's absorbed from your gut goes first pass through the liver before it gets to the rest of the body. Having said that, if you ignored that particular side effect, which sadly was fatal, but if you look at the other, it did not cause many of the other side effects of hormone therapy drugs. So you didn't get things like bone thinning. You probably did get breast growth, but many of the other side effects were not present. I don't think hot flushes were present either. So if it could be made to work, it's actually potentially a really good hormone therapy drug. Now, there is a trial going on at the moment with an acronym PATCH, which is very relevant. I'm sure they sat down and thought about that really quite hard, because the trial is to use estradiol, and estradiol is administered as a skin patch. So that goes straight into your blood. It doesn't go through your gut, and it doesn't do the first pass through the liver. And it's hoped that this will be a useful and valid hormone therapy drug without the nasty side effect that diethylstilbestrol had. I understand that trial is ongoing at the moment. One of the slight issues they have with it is getting the drug dosing precise with skin patches. Turns out to be somewhat difficult, but it would be nice to see that succeed, because it may produce a route to a hormone therapy drug that has considerably fewer side effects than the current hormone therapy drugs. Why is ADT effective for longer in some men than others? Going back to what I described about the DNA corruptions, DNA corruption is a random effect, and it happens all the time. And most of the corruptions probably render the cell, not useful at all. But just occasionally you get a random corruption that actually enables the cell to start running away and to defeat the current androgen deprivation therapy mechanisms. So it's a random event. It seems to happen more frequently on people with higher Gleason scores, but not always the case. So, as I said, it's likely to happen eventually on a balance of probabilities, but it depends when it happens to happen to you, and that really is quite a random effect. Is it normal to have more than one hormone treatment at the same time, and does it double the effects? What's normal? No, it isn't normal. So most men would be on a single hormone therapy treatment at one time, and then others are added as if and when that one starts to fail. Now, the two treatments at the beginning of the Prostat Zoladex decapeptyl to avoid the flare is a different case, and that doesn't really sort of figure into that in the same way. But if you're on one of those drugs and it eventually starts to stop working, you might get something like bicalutamide added, which is termed a total blockade. So you're trying to stop production of the testosterone, but you're also trying to block any remaining testosterone, because they don't completely stop testosterone altogether. And then there are, for people who are high risk or thought to, who are likely to fail the Zoladex Prostat decapeptyl or Digirelix quite quickly, then there is the possibility of abiraterone. This is obviously, this has been the subject of a rather sad NICE review just recently, where it's been denied to some men. But adding that early on may make the underlying Zoladex Prostat decapeptyl Digirelix last longer. Does hormone treatment prostat cause severe fatigue? Bed rest. A few hours is best treatment, it seems. All of those hormone therapy treatments cause fatigue, or can cause fatigue. Actually, I cover this in my surviving hormone therapy session in quite a lot of detail. You do get a reduction in red blood cells, to a small degree at least, and that can be a source of fatigue. The biggest antidote to that fatigue is exercise, and that really works phenomenally well in those who are capable of doing so. Now, of course, some people are not capable of doing so because of other disabilities, but if you can exercise, to quote a quote that I stole from somebody else off the internet, he just said, "I just felt the fatigue drain away," and it does. It works really well. So I would certainly recommend exercise, which is great for tackling many of the side effects of the hormone therapy drugs. Have you used any complementary therapies or strategies to reduce side effects? As in me personally? No, is the answer to that. I do use some complementary therapies, but not for not to distract side effects of hormone therapy drugs. Having said that, I'm lucky and I don't get the hot flushes, but about 80% of people on hormone therapy do get hot flushes. Some 6 years ago, I had 7 months of Zoladex treatment before 5 weeks of external beam radiotherapy and then brachytherapy. Does this 1 month treatment avoid what I understand is the effect of Zoladex over a longer period, male castration leading to impotence? So let me just read that to myself again. Some 6 years ago, I had 7 months of Zoladex treatment before 5 weeks of external beam radiotherapy and then brachytherapy. Does this 1 month, I'm not quite sure where the 1 month comes from, does this 1 month treatment avoid what I understand is the effect of Zoladex over a longer period?
Is it possible he means 7 months? Perhaps he means 7 months.
Oh, does this 7 months treatment? Okay. So that's termed, the treatment you had there is termed neoadjuvant hormone therapy. Neoadjuvant meaning the hormone therapy you have before your radical treatment, in contrast to adjuvant hormone therapy, which is the hormone therapy you have after your radical treatment. The neoadjuvant hormone therapy basically kind of down regulates the activity of the prostate. So the prostate is not, by the time you will have had your radical treatment, as in the radiotherapy and the brachytherapy, your prostate will have been, quite sleeping. It won't have been active in terms of cell multiplication. Your PSA was probably very low by then if you had it measured, and most people don't actually have it measured at that point. And that is thought to improve outcomes. So it's basically a question of you're hitting the prostate with as many things as you can at once. So you're stopping it from growing. You're hitting it with the radiotherapy, which is damaging its DNA. It's perhaps just worth explaining how the radiotherapy works there, because a lot of people imagine that it's like sticking a prostate in a microwave oven. It's absolutely not. The radiotherapy corrupts the DNA in all of your prostate cells, the good ones and the bad ones. Now, remember what I said was significant about a cancer cell? It's got a broken DNA repair mechanism. So if you corrupt the DNA in the cancer cell, it will struggle to repair it. If you corrupt the DNA in a normal prostate cell, it's got a working DNA repair mechanism, it will repair it. So this is basically the concept. This is how the concept of multiple sessions of radiotherapy work. So you hit the prostate one day, you corrupt lots, not necessarily all, but you corrupt lots of the DNA in the cells. The good cells then spend the next day repairing themselves, and by 24 hours later, they've repaired themselves. The bad cells will struggle and mostly won't have repaired themselves. You then hit them with the radiotherapy again. What happens? You corrupt the DNA in all the cells even more. Well, again. So the good cells are now corrupted again. Their DNA repair mechanism kicks in. It repairs it. The bad cells didn't manage to repair yesterday's corruption. You've now put another load on top. So their DNA has got even more corrupted. And you keep doing this. And as you can see what happens, you are accumulating more and more corruptions in the DNA in the cancer cells, but the good cells keep repairing themselves. So it may look like a blunt weapon, like sticking something in a microwave, but that's not at all how it's working. It's just concentrating more and more DNA corruption in the cancer cells. And the aim is that by the end of it, you corrupted their DNA so much that they actually can't multiply anymore. Doesn't mean they're dead. Now, some of them will be dead, and actually some of the good cells will also have been collateral damage in the process. But the aim is that all the cancer cells are past the point where they can actually reproduce anymore and generate new cells. And over the following 18 months or so, they'll die out of their own accord. Now, I'm trying to remember the essence of the question. By hitting them with the hormone therapy at the beginning, you kind of shut them down, so that even while you start hitting them with the X-rays from the external beam radiotherapy or any of the radiotherapies, they're not in a state where they can divide. So yeah, you are generating more and more corrupt DNA in cells, but the cells can't divide at that point because you've shut them down at the testosterone level by not having to. So it improves outcomes. There is some evidence that the lower you get the PSA before you start hormone therapy, that the better outcomes are later on. So some 6 years ago, I had, I joined late. Don't know whether you covered the situation that generally younger men have high testosterone and no prostate cancer. Older men have low testosterone level and prostate cancer. No, I didn't mention that specifically. I would rephrase that a little bit. You are right on testosterone level. Testosterone level tends to peak around 25 or so and then gradually declines. But on prostate cancer, I think I would say that younger men do not tend to have discovered prostate cancer, but older men are more likely to have discovered prostate cancer. If we look at autopsy results from men who died of other things totally unrelated to prostate issues, you tend to find that prostate cancer grows fairly linearly. So in the US, they discovered that 40% of 40-year-olds who died of other things when they went through autopsy had the beginnings of prostate cancer. Europe had already gone through and done some similar experiments and discovered that 50% of 50-year-olds and 60% of 60-year-olds and 70% of 70-year-olds, you'd see the trend, have prostate cancer. Of course, that doesn't mean that all those people will die of prostate cancer. Most of them won't, and most of them will never know in their whole lives they had it. But I suspect that's probably rather more an effect. I guess what you're asking is the lack of testosterone responsible for producing prostate cancer? And I would say I don't think there's any evidence to that effect at all. There are one or two people who think that the estrogen may be responsible for prostate cancer, but it's not a widely held view. It tends to be held in a few niche places on the internet. How important is it for a man on ADT to keep strictly to the 12-week injection interval? Very good question. I've looked at this for Zoladex, and unfortunately AstraZeneca published no data for what happens to your testosterone level after the 84 days, the 12 weeks. They do publish some graphs showing what happens before the 84 days. And in some people, it does start to wear off a little bit before the 12 weeks. So I would guess that if you go over the 12 weeks, the Zoladex would be wearing off in more people. Having said that, when you actually come off a drug like Zoladex, it does take quite a while before your testosterone returns. So, you know, if you occasionally go over the 12 weeks, I wouldn't get too concerned about it, but I wouldn't do it as a matter of course. So yeah, stick to the interval, which for Zoladex is 12 weeks, for Prostat is 3 months, subtle difference there. And I think for Decapeptyl is 12 weeks as well. Decapeptyl also has a 24-week version of it. I've heard people report that PSA level measured while on hormone therapy is considered to be twice the figure in reality. True, why? Yes, very good question. And perhaps I should have mentioned this when I was talking about finasteride. So I mentioned finasteride and dutasteride, which are hormone therapy drugs that are used for benign prostatic hyperplasia. They do slow down the activity of the prostate, and in doing so, they cause the prostate to reduce the amount of PSA that's produced. But that does not mean, you know, if you've got prostate cancer, that does not mean you've suddenly lost half your prostate cancer. So while you are on finasteride or dutasteride, if you are having PSA readings taken, for the sake of risk assessing you for prostate cancer, you need to double those readings. So if you end up, you know, if you've got a PSA reading comes back as 4 while you're on finasteride or dutasteride, you need to double it. So your real reading would really be 8. That doesn't apply to the other drugs that are actually used for prostate cancer treatments. But yeah, if you're on finasteride and dutasteride, and you are having your PSA measured periodically, as you should do remember to double the value.
Ooh, I think that's it, Andrew. Thank you ever so much, and thank you everybody for some really, really interesting questions there. I'm sure Andrew enjoyed having the opportunity to answer some that were slightly outside of the questions of this talk, but I know they're all really valuable. And as I've mentioned in the Q&A and the chat box, if you want Andrew to deliver this talk directly to your group, you only have to get in contact with him, and he will be more than happy to make that arrangement. And he also does the How to Survive Hormone Therapy talk as well. So just to say thank you everybody for joining us. We've really enjoyed delivering this and offering it to you today. It's goodbye for me. I don't know if Andrew, have anything you'd like to say?
No, thank you very much for listening, and thank you for the question.
Thank you very much. Goodbye everybody, take care, and we'll see you all real soon.